So welcome back, and I'm from Cochin. This is my center and the beautiful city of Cochin. Coming to the topic, today I am going to speak on protocols for immediate implant, immediate loading. So the protocols for implant load timing, we can load the implant immediately after placement, that is within a week. We can call it immediate loading implants. If it is after a week, within 2 months, it is called early loading implants. If it is after 2 months, once the implant is integrated, then if we are loading, it is conventional loading of implants. And in this type of loading, there are two subtypes. One is occlusal loading, and the other one is non-occlusal loading. Also, there is direct loading and progressive loading. Criteria for successful immediate loading. We need to achieve good primary stability for our implant. That is the most important thing. The insertion torque of the implant should be 35 newtons or more. If it is less than 35 newtons, it is not advisable to load the implant immediately. There shouldn't be any excessive micro movements during the healing period, during the osseointegration period. It should be always less than 130 micron. We should splint the implants. There should be a rigid splinting when we are doing a case of multiple implants. All the implants should be splinted together. And we must use an implant of minimum length of 10 millimeters. It is better to have bone type T1 and T2, but we have special gadgets to improve the quality of the bone now, like tensor drills, osteotomes, magnetic mallet. We can use these gadgets to improve the quality of the bone by densifying it. And whenever possible, try to achieve bicortical anchorage. Engage the second cortex to make the implants more stable. And another point, when we are doing full arch cases, it is always better to have a cross arch stabilization. So these are the criteria for successful immediate loading of implants. When we look into the literature, the most important thing is that the primary stability of the implant. If you fail to achieve primary stability, we may not be able to load the implants immediately. We have to allow it for a submerged healing. So the key factor is achieving good primary stability for our implants. I'll be sharing with you cases of immediate loading of single tooth, multiple implants, full arch cases, and extra maxillary implants. So let me start with a single implant immediate load protocol. In the literature, we see 82.4% of success for immediate placement and 100% success for heel size. This is according to this study which was published. So I am sharing a case where the maxillary lateral incisor got fractured below the cervical level, where we plan to extract the tooth and extract the tooth in a minimally invasive way, and place an implant and load it immediately. So every case we do a virtual planning. This case, we took the CBCT image. This is the 3D rendered image. And we did a virtual extraction of the tooth, of the fractured tooth. The implant was positioned. A virtual planning was done. And then we started with the real surgery. We need to do a less traumatic extraction. In this case, I have used a magnetic mallet for the extraction. This is how we use a magnetic mallet. This is of a different case. We work on the mesiopalatal and distopalatal aspect of the tooth. We want to preserve the labial bone, the bundle bone, which is very important, which is a part of the periodontium, and it is very thin. If you break the bundle bone, it is difficult to place and load and implant immediately. So whenever possible, we try to preserve the bundle bone by doing a less traumatic extraction. These are the gadgets which we use for less traumatic extraction. We can use a periotome, luxators, or a magnetic mallet. The extraction was done, and I started with the lancet drill. So whenever we work in an extraction socket, the slopy wall of the socket will guide the drill into the least resistant area. So always we start with a lancet drill and we work on the palatal wall of the socket. We want to place the implant in ideal prosthetic position. Then only we can give a screw retain prosthesis. So started with the lancet drill, and next is the tensor drill in reverse mode, so that the bone, whatever bone is there, we are preserving the bone and densifying the bone and improving the quality of the bone. Tensor works in reverse mode. Then the implant is placed. You can see the implant is placed exactly at the cingulum area of the tooth. That is the ideal prosthetic position. And in this case, we have used the patient's own fractured tooth. The fractured tooth we made as a provisional crown. We made a hole in the center of the fractured tooth and a plastic abutment. These type of abutments are used for screw retain restoration. Castable abutments is bonded to the crown using flowable composite. And the provisional crown is made. And the crown is fitted onto the implant immediately after the surgery. And you can see the patient reported to practice with the fractured crown and left the practice with the same crown, but the crown is on an implant. So there is no waiting period. The patient leaves the office with the crown. That is the advantage of immediate loading. Of course, we have kept the crown out of occlusion. During the healing period, we don't want any micro movements of the crown, of the implant. So we always keep it out of occlusion. Now I want to discuss with you multiple implants, how to load multiple implants. So sharing a case where The central and lateral incisors are fractured, previously root canal treated. And you can see there is some periapical lesion at the lateral incisor apex. So plan was to extract and place 2 implants and load it immediately. So this is the CBCT cross section of those teeth. You can see the radiolucency at the lateral incisor apex. This is the pre-op photographs of that case. Occlusal view. The tooth were extracted in a less traumatic way. We cannot call it a traumatic extraction because all extractions are traumatic. Here, it is less traumatic extraction. I have used magnetic mallet in this case also. And you can see a radiolucency here. That means there is no bone there. So before placing the implant, after curating the site, I wanted to remove all granulation tissue, infected tissue inside the bone. Removed the granulation tissue and packed a bone graft into the space. I used the Densa drill in reverse mode, condensed it well, then placed the implant. So this is the second implant. Both the implants, I could achieve good primary stability. And you can see the implant almost at the cingulum area of the tooth so that I can give a screw retain prosthesis. Open tray impressions were made on the same visit. Healing abutments were placed and the lab fabricated screw retained joint crowns, which was delivered after 2 days. Till then, the patient was on the healing abutment. You can see the soft tissue, nice soft tissue, which is maintained. In this case, if we plan for a delayed loading, we extract the tooth, place the implant, put sutures. That means the papilla will not stay there. We will never get such a beautiful soft tissue architecture. So this is the advantage of immediate loading in the aesthetic zone. The patient leaves the office with the teeth. No waiting period. Later, if it is needed, we can change the crown if it is needed because it's easy to change because these are screw retain crowns. Just unscrew it, make another impression, and we can fabricate another crown. And this is the final result of the case. Now I want to share with you full arch cases. Full arch, usually in the maxilla is divided into 3 zones. If we have bone in all the 3 zones, we can place conventional implants, conventional straight implants. If we have deficient bone in zone 3, we can plan for all on 4 implants. If there is bone only in zone 1, we can plan for zygomatic implant. If there is no bone in all the 3 zones, the treatment plan is the quad zygoma and pterygoids. This case, there is bone present in zone 1 and 2. So this is an ideal case for all on 4 protocol. Not all cases are for all on 4. Here, there is bone only in zone 1. So we go for extramaxillary approach. We place zygomatic implant. Here, there is no bone in all the 3 zones. So we go for quad zygoma. Only extramaxillary implants are possible in this case. So I want to share with you cases done in each clinical situation. This is a case, grade 3 mobile teeth infected. We plan for straight implants in this case, and we plan for crustal lift for the distal most implants. This case was done in a day. So we were planning to extract, place implants, make impression, and load it immediately. This is the pre-op radiograph. I mean, the virtual models. We can see the pre-op photograph of the case. Intraoral photographs. All the teeth were extracted in the same visit and implants were placed. What you see here is the mound. I just want to check the parallelism. So I put the mound into that and I am checking whether the implants are parallel to each other. Upper and lower. Upper, I have placed 2, 4, 6, 7 implants. The distal implants were done with sinus crustal approach. There was deficient bone. You can see the implant into the maxillary sinus. I did a crustal approach there and could achieve good primary stability for that, for those implants. Lower, we have placed 6 implants. And multi-unit abutments were attached. Why multi-unit? Because I want to give a better prosthesis. There is a protocol called 1 abutment at a time. So I am converting a bone level implant into a tissue level implant and also correcting the angulations of the implant so that I can give a screw retain prosthesis with better aesthetics. So this is the prosthesis which we made. On the second day, this was ready. After the surgery, we made impressions and our lab made this prosthesis. You can see the unhealed tissue. This is the third day after surgery. You can see the multi-units also. This is the prosthesis, screw retain prosthesis delivered on the fourth day after surgery. So this is the intraoral photograph immediately after delivering the prosthesis. Right occlusal and left occlusal views. And this is the immediate post-op radiograph of that case. There was a big defect here. We did some vicurity that area. I did some bone grafting there. This side also there was some defect. There also I did bone grafting. The distal most implants were with crustal lift, but those implants had good primary stability, more than 40 newtons. So I have decided to load it immediately. So this is before and this is after. This is before, this is after. So that's about straight implants. Now I want to share with you tilted implants for immediate load. So when there is no bone in the zone 3, zone 1 and 2, we have good bone. Such cases, we plan for all on 4 or all on 6. So to avoid the maxillary sinus, we tilt the implant anteriorly and we increase the AP spread. And we can achieve good primary stability using longer implants and bicortical anchorage, and we can load the implants immediately. This is a case where we did upper all on 6. This is the pre-op photograph, the case. This is the pre-op radiograph. You can see the maxillary sinus has come down. So we plan to tilt the implant like this on both sides. That is all on 4, all on 6 technique, and load it immediately. Every case we do a virtual planning. This is the 3D rendered image of that case. We did virtual extractions. The virtual extraction was done and we started with the virtual planning. Almost every case we do virtual planning because we all know implant dentistry is a prosthetically driven entity. So first we plan the processes. Accordingly, we place the implants. So this is the plan which we do. 6 implants. Distal implants were tilted and the center implants are straight. When we look into the literature, virtual implant planning allows a prosthetically driven approach, resulting in the best possible design of processes, better aesthetics, optimized occlusion and loading. We can go fully guided or partially guided, or at least do a planning. And in my cases, most of my cases, we do a planning and I go freehand surgery. But virtual planning is a must for me. Almost every cases, we do a virtual planning. This case, I used a pilot guide. We have a center, digital dental solutions, where we make all these type of surgical guides. You can see the distal implants osteotomy is done and the paneling pin is placed into the osteotomy through the surgical guide. You can see the paneling pins, surgical photographs, and 6 implants were placed, and you can see the multi-unit healing abutments. 6 implants, distal most implants tilted maximum to get maximum AP spread. Longer implants were used. We could achieve bicortical anchorage so that we can load it immediately. And in this case, we have made a conversion processes. Every case we use these abutments. In full arch cases, every case we prefer to use multi-unit. With this, we have many advantages. Usage of multi-units. We are bringing the bone level implant to a tissue level. And we don't need to remove multiple times. I mean, when we do a full arch case, we have to remove the processes multiple times for making the impression. We have to attach the impression post, remove the healing abutment. Later, we have to go for a metal try-in. Many times we have to remove and put in the healing abutment. But when we use a multi-unit, we are bringing to a tissue level, bringing it to the tissue level. So this has many advantages. We get nice soft tissue healing. We are not disturbing the tissue after the placement of the implant. You see, this process is without a multi-unit abutment. On the right side, what you see is with the multi-unit abutment. This goes into the bone level implant. Every time we remove it, we put it back, we are damaging the tissue. But when we use the multi-units, we are working on the tissue level, and we can achieve good soft tissue healing. So all full arch cases, we use multi-unit abutments. And we can give a screw retain processes. This is how we make a conversion processes. The denture was made before the surgery, and we attach the titanium, we attach the multi-unit abutments, and we use titanium cylinders, and we did the pickup. So you can see the denture with the female part of the multi-unit abutment, that is the abutments. And we can give a screw retain processes on the same day of the surgery, immediately after surgery. This is the processes which we made chair side, and it is delivered. It's not that beautiful, but the patient leaves the office with the processes. Later we can change it. So you can see the right occlusal and left occlusal views. And this is the immediate post-op radiograph of the case. You can see the titanium cylinders. The denture was reinforced with a mesh so that we need something rigid. So this is how the radiograph looks after a denture conversion. And this is the beautiful smile of the patient. This is the same day after surgery. Morning, the patient came. Afternoon, the patient left the office like this. And after 3 months, when the implants are integrated, we have removed the screw retain processes, and we are converting the denture, the conversion processes, we are changing into a PFM processes, screw retain PFM processes. This is the PFM processes, which we made after three months. And this is the smile of the patient before and after. Now I want to share extra maxillary implants, immediate load. When there is no bone there is no bone for the conventional implants, we place extra maxillary implants. So extra maxillary implants are the zygomatic implant and pterygoid implant. This case, you can see there is no bone in zone 1 and 2. There is some bone in zone 1. 2 and 3, there is no bone. So we plan for extra maxillary, zygomatic implant and pterygoid implant, and 2 anterior implants. This is the pre-op photograph of the patient. Intraoral photograph. Always we do a virtual planning. We did a virtual planning, and what you see here is a surgical guide. We never go a fully guided surgery in zygomas. This is just a marking guide. We just use this guide to mark the point of entry into the zygoma. First, we started with the pterygoids. We are placing the pterygoid implants. So this is the pterygoid surgery. You can see the drill position. This is how we angulate the pterygoid implant. These are the implant. 22 millimeter long implant we placed in this case with a polished collar. And we could achieve good primary stability for this case. More than 60 newtons of stability we achieved for the pterygoids. That means we can load it immediately. Then we started with the zygoma. We use the marking guide. You can see the marking here, the point of entry to the zygoma. We start with the diamond drill. We do the extramaxillary approach. This is an instrument called zygopath to make sure that we are away from the orbit. So this is the zygomatic implant. This case, we have placed a 50 millimeter long implant. And you can see the insertion torque of the implant. It's almost 100 newtons. So the left side zygoma is over. We started with the right side zygoma, the diamond drill. Again, extramaxillary approach, zygopath, and the implant is placed with high torque, almost 100 newtons of torque we could achieve. Here comes the multi-unit abutments. All our implants are placed in different directions. The pterygoids, the zygomas, and we place 2 nasal implants also. So now we need to make it parallel to make a screw retain prosthesis. So the multi-unit abutments are mandatory when we use tilted implants. So these are the multi-unit abutments with the stylus. And this is the healing abutments placed over the multi-units, and the sutures are placed. And in this case, we made an impression. Before that, we attached the conversion. We attached the titanium cylinders to the multi-unit, and we made the conversion processes. A denture was made before. Actually, the patient was a denture wearer. We converted the patient's denture to a conversion processes. You can see the multi-units on the denture. This is the inner surface of the denture. You can see the female part of the screw retain processes. And this is how it looks after the processes is fixed. This is fixed on the same day afternoon. You see the right occlusal, left occlusal, and the frontal view. And happy patient. Same day afternoon, patient left the office with a beautiful smile and fixed teeth. He was so happy. You see the before and after photographs. Before and after. And this is a immediate post-op radiograph of the case. You can see the titanium cylinders which we used to make the conversion processes. This is the pterygoid. The distalmost implants are the pterygoids, and the zygomas and the nasal, you can see. And we did a full digital protocol for this case for the final processes. This is the intraoral scan of the denture. Then we remove the temporary processes, and you can see screw retain temporary processes is removed, and the multi-unit abutment is scan body. Scan bodies are attached to the multi-unit abutments. scan is made. So the scanning part is over. We made an intraoral scan with the denture. Then we attach the scan bodies onto the multi-unit. Then another scan is made. Then we scan the processes also. Then in the lab, we did a fully digital workflow. This is the scan with the scan bodies. And this is the lab work, what they do in the lab, full digital protocol. I just play this so that you can see what all work they do there in the lab. So this is how they make the processes fully digital in the lab. And we made a milled titanium framework and a PFM processes. This is the processes. And this is post-op after the final processes, before and after. Now, I want to share a quad zygoma case where there is no bone in all the three zones of the maxilla. The only option is called extramaxillary implants, where we place quad zygoma, two zygomas on each side. This is the patient. She was partially edentulous from birth. There was no teeth. This is the 3D rendered image. There was no bone in all the three zones. So this is another view. So every case we do the virtual planning. So this case also, first we do the planning. We virtually place the planning. These are the four zygomas we placed virtually. So virtual planning is done and we printed a 3D model. And these are the markings which we made, the point of entry into the zygoma and our starting point. Usually we start at the 5 region, that is the second premolar region. And this is the intraoperative photographs. You can see the marks where we are going to enter into the zygoma. So the osteotomy, you can see the drills placed. These are the two zygomas with multi-units. 4 zygomas are placed. There is no bone to place any other implant. So only with extramaxillary implants, we manage the case. Lower, we placed conventional implants. And in this case, we have given a metal acrylic processes. This is the processes we made on the second day after surgery. Always we give screw retain processes. So this is a screw retain processes on the on the multi units of the zygomatic implants. This is after 3 days, after fixing the processes. Look at the smile of the patient. She was so happy. She was edentulous from birth, and she is getting teeth, that to fix her teeth in a day. Look at her smile. This is the post-op radiograph after loading the zygomas. So till now, I have shared with you single implants immediate load, multiple implants immediate load, straight implants immediate load, tilted implants all on 4, all on 6, zygomatic pterygoid implants. And now the last case which I want to share with you is patient specific implants. We have solutions for everything. When nothing is possible, like no other implant is possible, we manufacture implants according to the architecture of the bone. This is something like a subperiosteal implant. So, this case, the patient had a tumor surgery and there was no bone to place conventional implants. So, we made the scan and a PSI, patient specific implant, was made. And you can see the multi units attached to the patient specific implant. And this is the 3D printed model. This is the implant. And this is after surgery. Again, multi unit healing abutments. This is the implant. Impressions. This is the processes which was loaded again on the third day after surgery. This is before and this is after. Before, after. We have solutions for all bone defects. So this is the post-op radiograph of the patient-specific implant. So thank you so much for listening to me. Those who want to learn more about implants, and if somebody is interested to get trained, you are most welcome to attend our courses. We have the basic implant course, which we conduct once in 2 months. Now we are starting the 60-second batch. The registration is open for that. Ours is an ICOI affiliate study club. So those who wish to start their career, get trained in implant industry, you are welcome to join for the basic implant program. And also we have advanced programs like hard and soft tissue augmentation techniques, the bone grafting course, which myself and Dr. Tarun Kumar regularly conducts. So our next batch is in July. If somebody is already into implant industry and want to learn more about bone grafting, you are welcome. And we have the immediate load program, that is the ICY mastership program about zygoma, pterygoid, all on 4, all on 6. Also, we have the advanced prosthetic program, which is a part of the immediate loading program. Then we have another program, which is MS implant industry, maybe one of its kind available in the world. It's a 1-year program. It's a university program. The program is in 5 modules. One module we conduct at Cochin Implant Institute, and you have 3 online modules of you have to attend 3 months online sessions. And final module, you have to go to Rome, Italy, present your thesis. And if you successfully complete, you will be awarded Master of Surgery in Implant Dentistry from the Italian University. Thank you so much. Thank you for your patient listening. So if you have any questions, you can send me a WhatsApp message. I'll reply to you. My WhatsApp contact is there. 919447779626. That's my WhatsApp. Thank you. Thank you so much.
Thank you, sir. It was indeed a wonderful session. As sir said, you can feel free to post your queries to the WhatsApp numbers shown on the screen. So once again, thank you all for being with Online Dentistry. And here we come to the end of the session. So stay tuned till the next second Wednesday for another punching session from Online Dentistry. Thank you all. Good night.
Thank you.
Thank you, sir.
Bye. Bye.